Welcome to All Things Addiction, a series of conversations sponsored by the Recovery Centers of America, or ARCA. And in this series, we discuss all things addiction, from prevention, screening, harm reduction, treatment, and recovery support for individuals with substance use disorders and addiction. I'm Fred Rottnek. I am the Chief Medical Officer at ARCA, and I'm also the Program Director at the SSM Health St. Louis University Addiction Medicine Fellowship. Today, I'm joining Percy Menzies, President and Founder of ARCA, and our topic today is all things alcohol. Well, Percy, thank you for setting time for us to talk today about all things alcohol.
Yes, I think I even like the name All Things Addiction, because addiction is such a broad topic and we need to cover every aspect of it, not just at the level of the patient and family, but also at the policy level. I think what is concerning is because of the stigma that is so strongly associated with alcohol and drug use, that seems to proliferate all up the social ladder, right to the level of policy making and at the level of law enforcement, and the group just goes on. And
Exactly. And I think one of the topics we've discussed often is the lack of a coherent approach. And too often we have kind of a knee-jerk approach to a new substance hitting the street, a new problem. Even we saw that during COVID with an inconsistent approach to how we work with folks and families and communities. So let's start off with alcohol. We know that during COVID, for the first time in decades, number of people affected to the point of death with alcohol went from around 80 to 90,000 to almost double that. And the numbers went up in, I believe, 2020 and 2021 to about 178,000 people a year in the United States had deaths associated with problematic alcohol use. Well, Percy, it's 2025. Why are we still struggling with this?
there are several reasons. One is that, unfortunately, alcohol, which is the 800-pound gorilla, got completely sidelined with what was happening initially with opioid overdose and later on COVID. Now, alcohol is it's very much ingrained within our culture, within our society. So it's almost part of the food group.
Mm.
So during COVID and during the opioid epidemic, we just thought, hey, people are dying. People are injecting themselves with any of these drugs, heroin, fentanyl, they're dying. Since alcohol is a slow death, it never had the melodrama that you would see with opioids or with COVID. And we paid a price. And to the wisdom of the government, they deemed alcohol as an essential commodity. So people were staying home, liquor stores were open, they're walking down the grocery aisles and through the liquor aisles, and they had money in the pocket and lots of time to waste. And what we saw was shocking. At 7 a.m, they would have a happy hour, and we are paying the price now.
And the other thing is that alcohol, as you mentioned, is so much part of our culture. And it's also self-soothing behavior, right?
Mm.
And during COVID, people were afraid, people were on lockdown, people didn't know what was going on in the world. So we know that what would happen is that one of the ways that people would self-soothe was alcohol. And they also could get it delivered, right?
Yes.
At least beer and wine.
It could be delivered. Even restaurants could offer them, bottles of wine or glasses of liquor with the take-home packages.
Exactly. So one of the odd things, at least in my mind, about alcohol treatment is that it's really had, I guess because it's been around so long, a very tortuous relationship with evidence-based practice. We know that in the 1900s, physicians were actually starting to think of alcohol use disorder as a medical problem, but then boom, we had prohibition, where it turned into moral failing again, and weakness, and character flaws. And then we had AA, we had that start up. Then we finally had some really good changes happen with Betty Ford. But I would say, and correct me if I'm wrong, but I think Betty Ford's treatment was one of the first times medications were really offered, at least for the detox process. What are your thoughts on the medications that we have right now for alcohol use disorder, how they were developed and how they can be useful?
The treatment and prevention of alcoholism has taken a very tortuous path because we continue to see it as a moral failing. I mean, go back to the time of the Bible. Like, alcohol is mentioned over 150 times in the Bible, both positively and negatively. So it is so ingrained with the culture. So, well, we had Dr. Benjamin Rush, who described this as a medical condition. But the treatment is decidedly non medical, episodic, and often punitive. Go back to the first medication ever developed that was approved by the FDA, a drug called Disulfiram, or better known by the brand name Antabuse. It was a medication that if you took a pill and drank on it, it'd make you sick. It really, I think, in some way jived with the mindset of the puritanical approach that punishment is the best way to change people. And and many people believe that that punishment aspect of disulfiram or antabuse would change people. The effect was just the opposite. So we do see it now. Obviously, we have to applaud Betty Ford for the things that they do. But I think the dominance of the AA model, the 12-step model, this year is the 90th, 90th. It was done out of a sense of desperation because nothing worked. The treatment of alcoholism is nothing but a history of punishment for violating people's rights and doing some most horrible things. I mean, using drugs like cocaine, morphine, and so on, and benzodiazepines. So no wonder that people who are afflicted by this disorder needed help and said, "Enough is enough. We will not trust men."
Yeah, because at least they knew how to manage their alcohol
Exactly.
use. And when all of the treatments were things that were designed to make people uncomfortable or disrupt their life in general, it's not a surprise that people veered away from treatment options.
That's what I joke saying that the treatment was worse than the poison. So many of the medications, if you look at, if I often talk on the history of alcoholism, we use some horrible, horrible devices and medications that did more harm than good to the patients. No wonder that distrust still continues. But now we have made enormous strides understanding the neurobiology of alcoholism, and the medications we have are highly focused on targeting those aspects of alcoholism that give the patient a fighting chance with their life back.
As you mentioned with disulfiram or antabuse, it blocks alcohol dehydrogenase, and people get violently ill, even if they have what I always say, those little fancy European chocolates with liquor in the middle. Having people voluntarily take a pill every day that makes them violently ill just doesn't make sense. What about the next, medication that was well, maybe not the next medication that was used, but the next beneficial medication, Acamprosate. Tell us a little bit about that.
Well, Acamprosate was developed by a French company that was developed to help alcohol patients who have been detox of alcoholism to maintain their sobriety. Because we know in our field of addiction, the biggest challenge is relapse. They do well for a few weeks and then they relapse. So here was a medication that was developed to maintain the sobriety of these patients. But there were two major conditions. One is the patients had to be completely free of alcohol. So they had to go through the detox process before they started on it. And it made sense because it really affected it really affected the glutamate system that would allow patients to be more normal, to be more in balance with their sleep and so on. The limitation of acamprosate is that that medication has to be taken 3 times,
Mm.
which is the 3 times a day, excuse me. And that's a big challenge.
Yeah, as a family doctor, I always say any medication you have to take 3 times a day is not an effective medication.
Right, exactly that. So that was a major limitation of acamprosate. And, we tried to use it, but we desperately need more medications. And obviously, I'm sure we'll be talking about naltrexone, as one of the options. But we need tens of dozens of new medication, like we have medication in psychiatry. We've got medications to treat infective disorder. Why are we struggling with so few medications?
Right, because essentially now in the US, about 750,000 people a year dying from complications of alcohol, drug, nicotine use. And why has there not just been a renaissance or not even a renaissance? Why has there not been a real stake in the ground to develop medications for 750,000 people dying every year.
Because we have to get away from this mindset that it's a moral failing, it's a weakness of willpower, things of that sort.
Mhm,
So that is still so entrenched. That is the reason, we have close to 25 million people impacted by drugs and alcohol, and less than 10% are offered medication. The most common response is don't drink and go to maybe a self-help group like AA.
mhm.
That cannot be the response. We have to offer something to patients who are desperate for.
And I think it's particularly ironic in today's culture of medicine, where we're really starting to take a look at social and structural drivers of health. What are all those things that happen outside of a medical exam room, outside of a physician or nurse practitioner or PA's office that really affects our health? Things like the environment, things like genetics, things like epigenetics, right? That's moving forward so quickly in other areas of health. Sometimes that's called personalized medicine.
Mm.
But here, I feel like we're still stuck in the dark ages so often when
Yeah.
it comes to treating folks with addictive disorders.
We have to change the mindset of our elected officials and governments that alcohol still is seen as a major source of risk. That mindset has to change. I mean, a recent example is the UK. They said, "Oh, the economy is not doing well. We need to do something about it." So they came up with a brilliant solution. Let's keep bars open till 5 in the morning. So we need to have more bars. We need to increase access to alcohol to help the economy. Come on, give me a break. So this is the kind of mindset we have to change. We have talked about it many times. The two biggest drivers for any addictive disorder is access and price.
Mhm.
So they are trying to reduce the taxes on alcohol. They're trying to increase the access to alcohol. And then you expect people that, hey, and the people who are impacted by this, let's assume that just 10 to 15% are impacted. That's a staggering number. And we do nothing for them. We expect them to get well on their own without any kind of intervention.
Absolutely. And I think we're seeing that play out now with the wild, wild west of the cannabis market in the
That's right.
United States. But let's go back to third medication commonly used today for alcohol use disorder. Probably the closest we have to a gold standard today. Hopefully not the best we'll ever have, but considering what we have right now, naltrexone seems to be the most effective. So tell me a little bit about your experience with naltrexone.
I joke saying that my middle name should be Naltrexone because I got so passionately involved with this medication, primarily because of its unique pharmacology and what I encountered in terms of trying to introduce a new and exciting medication that would have helped tens of thousands, if not millions of people impacted by this. And naltrexone, the indication with alcoholism was purely accident. As most of you know, it was developed in the mid 60s as a medication to prevent relapse to opioid addiction. All opiates were very effective for that. It was rejected, but lo and behold, it was found to be highly effective to treat alcoholism. And it was such a unexpected observation. And of course, that observation led to clinical studies. And the federal government said, hey, we need something more because antabuse is not the answer. We need something. So 50 years after the approval of antabuse, the FDA approved naltrexone as a treatment to prevent and treat alcohol.
Mhm. And first version was pill form, correct?
Yes.
Okay. And so that's been around for quite a while. What year was that approved, Percy,
It
for
was
alcohol
approved
use?
the end of 94.
90.
Okay,
Okay.
so almost the last month of December of 94. So it really has been out for almost 31 years.
Mm,
Okay?
okay.
And yet hardly anybody knows that.
Right.
And I can write, and indeed I'm actually writing a book about naltrexone because this medication should have revolutionized the treatment and later on the prevention of alcoholism. And unfortunately, it was completely maligned, slandered, and just died on the vine.
I know that I graduated from medical school in '95. So I know I was never taught anything about naltrexone in medical school. It wasn't until later in family medicine residency that I learned about it, and mostly self-study, because I was taking care of a lot of folks with co-occurring mental illness, co-occurring substance. Now, Percy, I know the long-acting version is Vivitrol. How long has Vivitrol been around?
Vivitrol got approved in 2006. It has been out for a while, and yet it is hardly almost 20 years. And yet, it's not a first line treatment. Yes, we don't have any gold standards for any medication, but right now, naltrexone comes closest to a gold standard for the treatment of alcoholism, primarily because of its unique pharmacology. In many ways, it is the antithesis of disulfiram or antabuse. Antabuse makes you sick. This doesn't make you sick.
Yeah, how does it work?
Well, we are not quite sure, but what we know is that it blocks the endorphinic effects of one of the neurotransmitters called endorphin. So when you take your first drink or you start thinking about the alcohol, the body will release endorphin, which will go and then bind with the opioid receptors. And then in turn, it will then cause dopamine to be released. And dopamine, as you know, is the mother of all pleasure chemicals. So by blocking the endorphins, it gives the patient a fighting chance not to prime the pump, not to go to a second or third. But the first drink is, oh, it feels so pleasurable, let me have a second drink. But by taking away the high, which is caused by the endorphins binding with the opioid receptors, there's no high. And if there's no high, the incentive to take a second drink is not there.
Right, so the counseling piece that goes with the use of naltrexone or Vivitrol is you can try to have a drink if you'd like, but you're not going to get any of the pleasurable benefits from that drink.
Exactly.
You're not gonna feel relaxed, you're not gonna feel giddy, you're not gonna feel drunk, but as I like to say, you can still fall off that bar stool,
Right.
you can still walk into a wall, you don't want somebody driving, and somebody might still have a hangover the next morning because those are different neurotransmitter systems.
Exactly.
So you get none of the benefits and all of the negative consequences of drinking.
And we really have to take the time to explain what is naltrexone. I have even seen physicians who claim to be addictionologists struggling to explain to the patients what is naltrexone, why was the medication developed, and how to use. It's really sad that after 31 years, we are still at square one.
Yeah, that's why it's been a central part of my work at St. Louis U and also with our fellowship at SSM Health to really explain the medications that we have available to not only our patients, but to other team members, other practicing physicians, other residents, fellows, trainees, because there's work out there now to try to introduce this into standard curricula, but it's going to take a while for it to really take root.
Exactly. And we have nothing on the horizon. Naltrexone should have been the prototype, the medication that would trigger interest in developing other medications.
The penicillin of addiction
That's why I
medicine.
call it the penicillin of addiction. When we discovered a new class of medications, I really believe initially the discovery of naloxone should have been hailed as a penicillin moment, and that should have triggered the interest to develop dozens and dozens of new medications. Instead of that, they were needlessly either ignored, slandered, aligned, and just discarded on the ash heap of history. And that, I believe, is really a tragedy that is going to plague us for years, because millions of people could have been helped by the discovery of this new class of medications called opioid antagonists. And it's ironical that the opioid antagonist, there should not have been as much antagonism towards the opioid antagonist.
Absolutely. And what's ironic now too is that naltrexone's being explored for everything. Contrave has been on the market for some years now as a weight loss tool,
Exactly.
combination of naltrexone and bupropion, I believe, and it's successful. And now look what we're doing with GLP-1s, right? For everything that ails you. But let's look at it. If it works with addiction, wonderful. If it works with substance use, wonderful. Behavioral addictions, fantastic. But as you say, naltrexone and naloxone, the overdose reversal agent, never was greeted with the same welcome.
Exactly. And I've heard scientists say naltrexone is like a toxicology's dream medication. I mean, every medication has an overdose limit. We do not know what the overdose limit on naltrexone is, because if there is no benefit, there's absolutely no harm being done. That's the reason why it is used for weight loss, or people who are self-mutilators, for gambling, sexual disorder. It just goes on and on. It is such a unique medication. And I joke saying naltrexone seems to get better by the age. Usually medications over a period of time will manifest certain limitation. Like a good example is gabapentin. Now we found the abuse with that and things of that sort. Naltrexone, in its 40-year history since 1984, seems to get better. I mean, it was tragic that the federal government caved in and placed a black box warning on naltrexone. I believe that that was one of the reasons why the medication never took off. That has been removed, almost unheard of in the annals of FDA, that in 2013, the black box warning was removed. This seems to get better. Then we can, for the alcohol indication, you can use a higher dose. You
Mhm.
can almost use it like a pain medication or like an allergy medication. If the allergies are really strong, take an extra antihistamine. Same here, take an extra naltrexone pill. Can you think of any other medication that is that flexible and that that incredibly effective in the treatment and prevention of alcohol?
Absolutely, because I know that the standard in the US is that if a medication is needed, use the lowest effective dose of the safest medication. I think sometimes we've forgotten that in the
Yes,
world of addiction medicine. But as you mentioned, boy, there's not many meds we can say, take 1 tab a day, for example, 50 milligrams. But as you mentioned, the higher dose tends to work better for many people, so 2 tabs a day. But having that flexibility, do 1 tab or 2 tabs a day is huge because life happens,
that's
right?
right.
People lose their jobs, lose their home, might have relationship difficulty. As the certified peer specialist will tell us, it's all about people, places, and things. And when things are bumpy, you can take an extra tablet.
Exactly.
How many meds, as you mentioned, can we say that about?
And naltrexone's benefit is that it allows you to get well in the natural environment that created the problem in the first place. You don't have to go away to California or Arizona and and really wrap yourself in a bubble that makes your addiction even stronger. And we often joke saying that you are in the treatment center, but your addiction is in the parking lot doing push-ups. Here, you are actually uh, in an environment where you can be exposed to a myriad of cues and triggers. And when those don't bother you, that is successful treatment. So here is a medication itself is very inexpensive. The generic is about $1 a pill. You don't have to spend $50,000 going away someplace. You can get well in where you are working and living. I mean, this is like a dream medication, a dream treatment environment. And yet the tragedy is that we are flaunting. We are just rejecting.
Well, and the other thing too that reminds me of, even though we know, which is a great thing, that younger generations are not consuming as much alcohol as people my age did when we were in our 20s. The social pressures aren't there. People are more likely to get a mocktail if they want, or just not drink. Granted, they're using a lot of cannabis, but that's a conversation for another day. But one of the other unique properties of naltrexone is you don't have to quit alcohol completely in order to benefit from naltrexone. Can you comment a little bit about
Well,
that?
I'm glad you brought that up, Fred, because that's one of the unique features. Now, with any disorder, especially that involves lifestyle, it's like saying, I want to lose weight. You cannot lose 50 pounds in a week. It has to be a gradual process. And naltrexone is uniquely geared to help you achieve their goals. Since I opened the clinic almost 25 years ago, that's what we tell. Okay, you're drinking 2 bottles of wine. You're consuming a case of beer a day. Now on naltrexone, it really helps you to reduce your drinking. So instead of 2 bottles of wine, now you're initially counted to 2 glasses of wine.
Mhm.
That's huge. And that's exactly what we call harm reduction. And why not utilize the unique pharmacology of naltrexone to, to really offer harm reduction in the treatment or in the approach to alcohol?
Yeah, because we don't have that flexibility with disulfiram or acamprosate.
We don't have.
What a luxury to be able to start the treatment and, for lack of better terms, see what happens, right? You're gonna see some benefit right off the bat.
And alcoholism is so entrenched into the physiology and psychology of the patient that it's like asking you to, I joke things like asking me to give up Indian food.
Mhm.
Asking somebody to give up alcoholism at the first attempt is completely unrealistic. And alcohol allows them to achieve those goals. How many times I had some very well to do patient that came and said, look, I'm not willing to give up my expensive red wine or my scotch. I can cut down, but I'm not willing to give it up. Fine, we'll work on your goals.
Mm.
Take the naltrexone pill, one in the morning, and before you drink, take an extra pill. It is amazing. And I have patients who said after about a week or a month and said, I don't even miss my wine anymore. I quit. Now, that is more effective than telling them you will do this or you will not do that. Let them tell my staff, roll with the punches,
Mhm.
and let them then decide that this is my goal.
Right, and building off of that person's autonomy.
Exactly.
Help them be successful rather than you say having some external locus of control coming in and saying, you have to do
Right.
this. Last thing I'd like to talk about today with this is what are some of the ways that all of us who work with folks who might have problematic alcohol use, we'll focus on that today. What are some ways to broach the topic? How do you like to talk about this to introduce the topic about alcohol use?
When they come, and I think especially I talk to groups really on how do you seek help, because a lot of times what we see is that people do realize that they have an alcohol problem, and we use an old system called cage quite
Mhm.
often. Cage stands for C stands for have you felt the need to cut down on your drinking? Have you felt annoyed or angry when somebody talks about your drinking habit? Okay. Have you felt guilty about your drinking? And the E stands for you need an eye opener to begin your. They're a simple test. I think what I see over and over again is that people who have either problematic drinking or they have a full blown problem with alcoholism do not know there are treatment. And I would like to, get up on a highest mountain at the top of a building and shout saying, guys, do not despair. We have treatment options for you. You don't have to go to jail. You don't have to go away to California, Arizona to get well. We can get you well. It's like treating you like you have hypertension or you have any other condition. We can treat you. And I really believe that the treatment of alcoholism should be akin to helping people get off smoke. If you have a problem with smoking, it is done in the environment you work and live. We can do the same thing for alcoholism.
And it may take more than one attempt, and
Yes.
that's okay. And the reason I always am interested in your perspective on this is because from my experience to medical and resident physician, I always work with them to try to normalize these conversations. Make these questions things like you would ask in
Yeah.
every other patient encounter. Not everyone, but at least once a year. And I always say, make it an open-ended question. Tell me about your alcohol use.
Exactly.
Assume everybody drinks. That's what I always tell them. Assume everybody drinks. So tell me about your alcohol use. If somebody doesn't drink, they're going to tell you. If somebody does, they're going to bring up what's most important to them. And then you can ask more focused questions. But it's that idea of allow people to raise their concern and give them that opening. Because too often in healthcare today, we still have that provider who says, you don't drink, do you? You don't smoke, do
No.
you? And that doesn't do
Yeah.
anything to move the conversation
Yeah,
forward.
because your liver enzymes are elevated. What happened? I went to the ball game yesterday. Okay, so on.
Yeah.
So assume that the patients are going to be very coy about admitting to the problem. But what we need to do is that we need to start. I mean, I say this over and over again. The gateway to addictive disorder, gateway drug to addictive disorders is not smoking, not marijuana. It is alcohol. It is the biggest problem. And we see this at every aspect of society high school students, college students, clergy, physicians, you name it. And
Lawyers.
lawyers, a huge problem. Almost 17% of lawyers have a problem with alcohol or drug, mostly
Yeah.
alcohol.
Physicians, it's about female physicians, about 21%
21.
meet screening criteria. Male physicians, about 18.
And yet, they hardly know about the treatment option because they're more familiar with the negative aspects of naltrexone carries a black box. Even physicians do not know that it was removed in 2013. So now the opportunity to prescribe it is a lot more expansive and safer.
Mhm.
So we need to get, and unfortunately, we always make offers that will come and talk to your group. We will educate them. How often? Very rarely we call, because alcohol is the 801 gorilla nobody wants to talk about.
Until it becomes so
So,
problematic that people scrape bottom, right?
exactly.
And if there's one thing we've learned in working with folks with addiction, they don't need to scrape bottom to get better.
Exactly. You don't have to lose a couple of toes before you treat your diabetes. Why? When the early signs occur, and use that cage analogy over and over again, when the early signs occur, look for treatment. And can you imagine that you take a pill that costs less than $1 a day, and that can cure you of one of the most debilitating problems we have in society, and yet we are ignoring?
Well, I think what that tells us is we've got plenty of conversation to have when it comes to all things addiction. And I think today was a great start. This idea of what are the options? How are we helping people know there's treatment, there is hope. You don't have to hide, you don't have to be afraid of bringing things up. And we're leading the field here at ARCA in terms of outpatient ambulatory care of folks with substance addiction disorder. And as SSM Health in St. Louis U, we're working on creating a workforce to train up folks to find compassionate, evidence-based practice to work with individuals, families.
I'm simply delighted at this opportunity that we are making such an important contribution to society and helping people, because we cannot simply live with 178,000 people losing their lives and countless others debilitated with all sorts of alcohol related morbidity.
So thank you for joining us today for this discussion of problematic alcohol use and alcohol use disorder. You'll see our contact information on our website on the screen below. We look forward to bringing you more conversations around all things addiction. Again, I am Fred Rottnek, Chief Medical Officer at ARCA, Program Director of the Addiction Medicine Fellowship at St. Louis U and SSM Health. And I joined today Percy Menzies, our president and founder of ARCA. Thank you very much.
Thank you.